Yo, yo, yo. Hey guys, welcome back to another amazing edition of the Best Practices Show podcast. My goal is to find the greatest rock stars, thinkers, coaches, teachers, influencers anywhere in dentistry and share great information. And today we have a huge rock star on the podcast. Her name is Dr. Bockow, one of the best thinkers in all of dentistry. And she said, can we talk about this? Let's talk about reframing the conversation around our orthodontic goals. And it is awesome. I'm going to highly encourage you to listen to this. So please listen up. I hope you enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. You know the jam around here. I get the coolest rock stars in all of dentistry to share some thoughts to help you improve your practice and your life. And I have one of the coolest rock stars of all time in dentistry. Her name is Dr. Bockow, and she's been a regular guest on our podcast. And if you haven't seen her, I'm going to encourage you to see her somehow, some way, because she's brilliant and she's a really good person. So today we're going to be talking about how we reframe the conversation around our orthodontic goals. Becca, thank you so much for being back.
Thank you. Thank you so much for having me, Kirk. And thanks for just promoting dentistry and all these new ideas on your podcast.
Oh, I love it. We're going to keep doing it. And you'll see. And Becca's been around for a long while. And she is an educator who's very thoughtful, pragmatic. And you also are very good at calling out the real issues. And I think you're a fabulous speaker too. So this is a conversation that came up recently. And I want you to talk about why we titled the podcast that today. Can you just talk about the why?
For sure. So in the world of orthodontics, there's a lot of controversy right now around is orthodontics indicated as a member on a sleep management team for children and adults. And overwhelmingly, I think we can all agree that we can't claim that orthodontics alone can cure sleep apnea. That doesn't mean that we as orthodontists don't have a role somewhere on this team. But I think some of the concern is that people will use, some people may, I might need to rephrase this, rethink this. I think the concern is there's risk for overtreatment. And I want to reframe the question. I want to reframe the concern, reframe the goals. Early orthodontic intervention has a lot of potential to help redirect growth and to help the system work in harmony. So what do I mean by that? If we think about a child and we can then translate that to the adult, we want to have health of the system. And that means lips together, tongue up, to be able to chew and function without overtaxing the muscles. We want a child and an adult to be able to speak, swallow, communicate, and function with the system in harmony. So we want the teeth centered in the bone, which protects the periodontium. We want to have well intercuspated teeth. And so historically in orthodontics, we've always wanted to achieve that goal where the teeth all line up well. We still want that. But but we want that also thinking about the teeth in the face. And so, for example, if the teeth line up well, but the jaws themselves are down and back, or maybe there's vertical maxillary excess and mandibular retrognathia, maybe that's a better example. So if the jaws are down and back, on a tabletop, if you have a set of study models, they fit together. You'd say this is a great finished case. But if this distance is so long, then that patient is constantly working to keep lips together, which stresses the system. And you can have muscles that are working too hard that can lead to jaw pain, that can lead to mouth breathing. Mouth breathing leads to downward, backward repositioning of the lower jaw, which can impact nasal breathing. The nose is use it or lose it. So there is a whole concept of nasal disuse. If this distance is too long, patients are more likely to mouth breathe. We don't see the nose breathing, and the nose gets boggy. The nose, we start to see more turbulence. We see more turbinate hypertrophy. And that leads to other downstream impacts. And so, and then thinking about speech, if the patient is working to keep lips together or working to move their jaws in different directions to generate the sounds to communicate, it can lead to muscle fatigue. It can lead to joint breakdown or joint soreness or other problems down the road. And so if we reframe how we approach our orthodontic care, and we don't just think about how do the teeth fit together, but we think about the system as a whole. And so really thinking about tongue space, really thinking about lips together, thinking about establishing this harmony.
I love it. I love it. And the choice of words. Now you're an educator. And so, one of the things that happens in education as people learn more, they get divided. It brings us together, but we also get divided. And you mentioned that if you just talk about a few things, sometimes people shut down, in the industry, like, oh, it's sleep, and they don't even want to listen to the rest of it. And that's why when you talk about if our target is healthy function of the system, we can all enjoy this conversation a little bit better, right?
For sure. There in the orthodontic circles, there was a white paper that was written by the American Association of Orthodontics, and the conclusion was that orthodontics does not cure sleep apnea, and I think that's well established. And so some orthodontists, if they hear, well, oh, this is someone that's trying to do orthodontics in an attempt to cure sleep apnea, I think that's not what the aim is. The aim is not to cure sleep apnea for many practitioners. It's to reestablish a healthy system. And so, for example, if you have a child that has enlarged adenoids and tonsils, their mouth breathing, tongue is low, and they happen to also have sleep apnea, they probably are presenting with crowding. So they have breathing issues, they have sleep issues, and they have craniofacial issues, and they have orthodontic issues. And so as orthodontists, we do have a place on that team. We in many instances can expand. In many instances, we can bring the jaws forward. But we also, in many instances, are working with ENT. We're working with allergists. We're working with sleep medicine. And it takes everybody to work together, to work with constant communication, to talk about timing, to talk about intervention, ultimately to attempt to rehabilitate a child or an adult if it's an adult. It's not just one person that's working to help the patient. On that note, also, a cure for sleep apnea might not be our end goal. It might not be possible, I guess is what I'm saying, but it's still productive.
Yeah, I love it. And we're going to talk about some of the things that you have done and a course that you're doing with Dr. Gunson, working with other professionals. You probably already hear this, But Becca, I understand it's hard to work with other professionals. Sometimes people don't understand me. So if I'm a dentist listening and I'm totally picking up what you're putting down, I'm like, give me some insight. If I'm a 32-year-old dentist and I'm like, I see this, it does require you have to go slower in some cases. You got to be a little bit more patient. You've got to be able to communicate. Those are natural, inherent challenges to doing more comprehensive work like this, don't you think?
Yes. Well, and I think also for the restorative dentist listening, maybe you'll say, well, I don't treat kids, I see adults. I think even just understanding what's happening when you see a patient is valuable. For example, an open bite. I practiced as a restorative dentist for a few years before I went back to my residency. I remember I saw open bites, saw a woman, and she just wanted it to look better for her wedding. So I added some composite. And I look back and I think, gosh, I wish I would have taken the time to try to understand why she had the open bite in the first place. Was it joint breakdown? Was it tongue dysfunction or a dysfunctional swallow? Was it narrow arches? Was it secondary to trauma? Was it an airway issue? Why did she have the open bite? Did I add a little bit of composite and cause a problem? Probably not. But had I done a full mouth rehab and tried to close the open bite, that could have caused some problems, maybe, because I didn't understand the true origin of the open bite. And similarly, gummy smiles. I think a gummy smile, I thought, oh, well, is it gum? Is it super eruption? But I don't think I truly understood that in many instances, it can be secondary to downward backward growth. And you probably can trace the origin to mouth breathing in early childhood. And so a gummy smile is actually a three-dimensional issue because it's vertical maxillary excess combined with mandibular retrognathia. It's downward backward growth. And it comes with a whole host of other compensatory secondary issues like difficulty with bringing your lips together. And so to look at just one finding as dentists, we weren't given the tools in dental school to truly understand the system. And that's where I get very excited, and that's where I've spent a lot of my personal learning is thinking about how does the system work as a whole.
Yeah. So true. So true. Now you use the words early intervention. I love it. Can you just better define that or go back to that? So if I'm listening, how do you define that?
Absolutely. So I'm trying to think of a very straightforward example. Let's say you have a child with a narrow upper arch. Narrow upper arch, oftentimes children will compensate. So if you have a narrow upper arch and it's quite narrow, they'll learn that they can shift their lower jaw to one side. And by doing so, it helps the teeth come together better. So clinically, that looks like a unilateral crossbite. But if you look at them smiling, you'll see that the chin is deviating to one side. If you catch that early, it's what you can do is widen that upper arch. And many times, most often, the chin ends up recentering itself because you've removed that compensatory pattern. And so by just expanding the upper jaw, not only are you making space for the teeth when you do that, but you widen the nasal floor. As you widen the nasal floor, you improve nasal breathing and you create space for the tongue. So you've improved this patient. Now, they may or may not have come in with a concern relating to breathing, but regardless, you've done this anyway. So you widen the nasal floor, you increase something called the internal nasal valve. You improve the body's ability to breathe more efficiently through the nose. You secondarily create more space for the tongue. And so now indirectly, you have improved the airway by improving nasal breathing, by opening up the back of the throat because the tongue has come forward. And you also have created a healthier periodontal situation because the teeth are now centered in the bone. So the top teeth are centered in the bone, lower teeth are centered in the bone, and you have a better occlusal scheme. So now the teeth fit together better. The soft tissue is protected. And now if you think about joints, imagine what's happening to the muscles and the condyles and the fossa if you have a patient constantly biting to one side during these formative growth years. The mandible is growing tremendously all the way from birth through puberty. And it has times where it ebbs and flows based on a number of things, hormones and dental development, but also things that influence mandibular growth include how we breathe, where we position our tongue, and how we load the joints. So now you have a patient biting to one side for these formative growth years. If you don't treat that, you run the risk of developing a skeletal asymmetry, including asymmetrical muscle development, dental alveolar development, and even condylar development. And so it's everything. By just fixing that crossbite in a young child, you've improved nasal breathing, you've improved tongue space, you've improved sleep and breathing, you've also improved the periodontal stability of the teeth, hopefully long-term dental health, but also joint health and muscle health.
Yeah.
So that's a simple example. So early intervention, to go back to your question, is simply getting the bones in the right place.
I love it. And so it's a lot to think about, if you haven't been exposed to this information. And as you start to work with other specialists, other people in dentistry, it's amazing what you get known for. One of the questions that I always get is like, people see this, dentists see this, but can I be able to practice doing this? Is there enough? The more you step into this, the more you get known for this, and the more cases you get sent for this. Is that correct? I mean, as you start to go down this path?
For sure. And I think also, so I think it's establishing your place in your community. You become a go-to person as a resource, even if you don't provide these services. So thinking about the restorative dentist that's identifying these patients, you become a resource for these patients. And yes, you still have amazing opportunities to do wonderful dentistry, but the hope is that it's more long-lasting and that you can help get these patients healthier long-term, because you may have patients in your practice that have been struggling and they don't have a name for it, or they didn't know that they could talk to their dentist about it. Open bites are another great example. I like to understand the why behind the malocclusions that we see. So if you take a child and for some reason they have that tongue coming forward, we run into a lot of chicken and egg questions when we have open bites, because is that tongue coming forward to protect the airway? Do they have enlarged adenoids and tonsils? Do you take out the adenoids and tonsils? Do you expand? Do you do myofunctional therapy? And many times we have to do all of the above. So for us, when we see open bites, trying to really understand where it's coming from. Is it a tongue tie? Is it adenoids? Is it tonsils? Is it lack of tongue space? We will often expand and then follow up with ENT, with allergists, with myofunctional therapists as needed. And oftentimes when we do all of that, the open bite closes naturally. And it's quite powerful for these kids. To swallow a bolus of food, we need to create what's called a perioral seal. So you need to bring your lips together, or you need to push your tongue against your teeth. And so if that's become a learned habit, that if the open bite is there, that tongue will go into that space. And so it becomes challenging to figure out how do we address it as an interdisciplinary team. So now translate that to your adult patient. If you have an open bite, if we simply, or even a teenager, if you simply put braces on and try to close it, our body's desire to breathe is often going to beat our orthodontic forces in many cases. And so if we simply, as orthodontists, close that open bite, or as restorative dentists close that open bite, but that patient needed that space for their tongue, and we didn't address that space issue or the breathing issue, our dentistry will break down.
Yeah, I love it. I love it. And when you take a look at the entire system, healthy function of the system, what are some of the things that most people get wrong about defining the health of the entire system?
I think I think some of these examples, like how do we treat an open bite, is a reasonable one. I think I I think historically, another one, might be how we approach jaw surgery. So historically, if you have a patient with an underbite, we didn't historically, the surgical world historically didn't have great methods for bringing the upper jaw forward. And so many of these patients received a mandibular setback. And so now you have teeth on a bench top that fit together well, but if the true diagnosis was deficient maxilla and you brought the lower jaw back, the face doesn't look harmonious. The face might not look healthy. You may have sag here of the muscles. I'm sorry, of the skin, because now you have a less prominent lower jaw. You have less tongue space, and you actually have encroached on the airway. And so going back to what we said at the very beginning, the teeth may fit together, but the system isn't functioning at its ideal, at its healthy state. And so really being thoughtful, it's not just how the teeth come together, it's how the system works.
Yeah. You have another thought on that?
I think there's a lot of debates around extractions in orthodontics, and I think you could make the argument in both directions, for and against extractions. So, for example, if you have an open bite, I'll go back to open bites. If the true diagnosis is lack of tongue space, the true etiology, if you take out 4 teeth to close the open bite and you haven't dealt with the lack of tongue space, chances are you'll see some relapse because you've closed down that tongue space in an attempt to get the teeth to come together, but you haven't truly understood the etiology, and chances are that won't be stable. On the flip side, let's say you have a patient with extreme crowding and you line up the teeth and you don't take teeth out, you can create protrusion. You could create a situation where they can't get their lips to come together. And so you've created a problem that you didn't have. And so that patient may have been a candidate for extractions. So I think you could make the argument in both directions.
Yeah. So well said. You introduced me to Dr. Tonini, remember that?
Yeah.
Who wrote the book on imaging. And one of the things, I mean, it was a powerful interview. So if you're listening, you got to go back and listen. She was talking about 4D. I didn't know what she was talking about. She's like, well, there's a 4th dimension. I'm like, I have no idea. She goes, time. Over time, things change. And so can you talk about the 4th dimension in all of these components of the system?
Sure. Well, I think the periodontium is a great example of that. So if we take a 12-year-old and we line up the teeth and it looks really nice when we're done, and we send them on their way, we might say, hey, as an orthodontist, we did a good job. If we look at the original records and we see that they actually had a deficient maxilla, and we went ahead and compensated them dentally, it is possible in some cases, if we don't truly diagnose the case, that we've inadvertently pushed the teeth out to the limits of the bone. When they're, call them 13 and a half, 14, when they finish comprehensive ortho, it might look okay, but histologically or radiographically, if we take an x-ray, you may see that the teeth are really at the limits of the buccal plate. So long term, that could potentially turn into recession. And so short term, it looks okay. Long term, it doesn't look okay. Similarly with joint breakdown, we may finish a case and it looks okay, but if they had an underlying compensation pattern that we didn't address, over time, those compensations start to express themselves. It's no different than, let's say you take a teenager who runs track, but they have a leg that's shorter than the other. They might not have pain when they are a high school track runner, but if they start if they continue to run into their 20s and 30s, they might develop hip problems and back problems and knee problems because they're constantly compensating for the short side. So breakdown is seen over time.
Yeah. It's so good. One thing I've never asked you on the podcast is you do a lot of these great courses. How did you, and we're going to talk about the course that you do with Dr. Gunson. So if you're listening to this, you might be thinking, this is a lot. You can actually spend some time with Becca and some other great people to learn more about this. But I want you to talk about the origin. Now, he's an oral surgeon in California. First of all, how did you guys get together? How did this come together? Can you talk about the origin of that?
Yeah, we both were invited to speak at a symposium that was put on by Spear Education, and I was citing a lot of his papers, and I was talking a lot about ideally positioning the central incisor in 3 planes of space and utilizing the central incisor as a benchmark for how to set up the rest of the teeth and the bite and the face. And then he came on and he talked about mouth breathing and the dangers of mouth breathing at an early age and how we really want to address that at an early age and what that looks like in an adult. And so we spent some time talking after, and we developed a great friendship and a great professional relationship. And I feel so fortunate I get to share patients with him. And we've really evolved in how we look at cases and also in our teaching. He jokes, he says, you can see the orthodontist earlier, you can see me later, because a lot of what we do in early growth guidance is helping. We're not always successful, but we really are trying to guide growth to eventually avoid surgery, if that's possible. It's not always possible, but that would be a great goal. And so if we can guide growth or prevent bad growth, then they hopefully won't need jaw surgery. At the end of the day, the goals are the same, whether it's a child or an adult. We want lips together and a healthy periodontium, healthy bite, healthy joints. And so that's the title of our course, Healthy Growth, Healthy Faces. And it's really about the system. It's about speech. It's not just how it sounds, it's how we recruit our muscles to make the sounds. And so if you have, for example, an overbite and you're constantly shifting your jaw forward to make the S sound, what's that going to do to your joints? What's that going to do to your back teeth? And so everything so like we just said with time, might be okay when they're young, but what happens as they age? And I think, Kirk, that's another hard thing is to identify with a lot of this, is you may see 3 patients in a row where they have a malocclusion but no breakdown or no symptoms, but then you might have one that has tremendous breakdown. And so why is it that some people do pretty much okay? They're relatively asymptomatic with the same problem, and then somebody else is symptomatic. And so I think for us that's good and bad, trying to determine who is going to have breakdown, and or if you find that one that does have breakdown, trying to understand the why.
Yeah. And talk a little bit more about the educational effort, because this is a big part of what you guys are doing, is reframing the conversation around orthodontic goals and the system goals. Are you the 2 main instructors in the course? Do you have anybody else that helps you with the course?
Just us.
Just the 2 of you.
And it's everything, Kirk. It's growth and development. It's width. So it's talking about expansion and the transverse dimension. We're looking at vertical dimensions, vertical growth, which includes gummy smile, downward backward growth. We talk about underbites and overbites and open bites. We talk about joints, joint health, speech, connective tissue disorders, and other systemic issues that can influence growth, sleep, airway, and just how do you take a child or an adult and get them to a place of health?
Yeah, I love it. So how many days is the course? Is 3 days or 2.5 days?
Three pretty full days.
3 pretty full days. So It's on September 26th, 27th, and 28th. Can you tell our listeners, where is it at?
The shores of beautiful Kirkland, Washington. So just outside of Seattle.
Love it. Love it. Love it. What else can I expect if I go to this course?
It's a great course because we really attract a lot of different professionals. So we have speech therapists, ENTs, myofunctional therapists, pediatric dentists, oral surgeons, orthodontists, and of course, restorative dentists. And everyone comes together and we all learn a lot from each other. I think many of the listeners that are CE junkies probably know so much of the learning comes during the breaks and at dinner that evening or over the lunch table, talking it out and talking about the things that we see and saying, oh, hey, that case reminded me of a case that we're treating together. Maybe we can rethink how we're looking at that case. So I think the power comes from the camaraderie and also the professional relationships that you build at these meetings.
100%. So if you're listening to this podcast and you're not taking notes, don't worry, we're taking notes for you. So you can flip up to the notes. If you're driving, well, not while you're driving, but after you're done driving, you're going to see a link to the course. And I'm going to highly encourage you to check it out. I promise you, you will love it and you'll learn a ton and be surrounded by some great people. So, Becca, give us some final thoughts before we say goodbye on, this conversation, reframing the conversation.
I think, well, first, Kirk, I just very much appreciate you getting this message out. I think it's an incredibly exciting time in dentistry. It's not just about straight teeth anymore. It's not just about cosmetic dentistry anymore. We really have an ability as dentists and dental professionals to make our patients healthier. We can ask new questions today. We can work on an interdisciplinary team in new and different ways. And we really have an opportunity to set our patients up for health. And that's really empowering. It's really exciting. It makes practice exciting. It makes it fulfilling. It also invigorates teams and it invigorates communities. And so it is so exciting. I think we're just on the tip of the iceberg here and it's just growing. The momentum's growing, the excitement's growing. And for anyone that wants to learn more, please reach out to me, but reach out to other people in this community that are also on the same journey.
Yeah. I'll say this about you forever. There are people that do dentistry and orthodontics, and there are people that change lives, and it's not the same business. And I know you're changing lives. So keep up the great work, my friend.
Thank you. Thank you, Kirk, for the invitation.
Absolutely. We'll stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show. Hey, if you enjoyed today, do us a favor, hit the share button, share this with your friends. Keep sending the word out there. I don't know how it's getting out there, but I really appreciate it. And keep sending us suggestions for things you guys want to see. We will line them up with Becca and some other rock stars in dentistry. So until we see you guys next time, or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.